I'm Dr. Hoagland, and I just want to provide this video for you to help you have a refresher on neurogenic language disorders in adults. So basically, I'm talking about aphasia. Before you watch the videos on Master Clinician Network, this is just to help make sure you're remembering the kinds of things you need to know when you're watching therapy sessions with adults with aphasia. So these slides are intended to give you that background and make sure that's all fresh in your mind. So we're going to talk about stroke and aphasia in this video. So generally, aphasia is a result of a stroke in individuals. And a stroke or cerebrovascular accident, CVA, is a loss of brain function, and that brain function, when it affects language areas in the brain, will result in aphasia. So this is due to a change in blood flow to the brain, and we see that again with a stroke. We have different kinds of strokes that affect blood flow to the brain, and we're going to talk about those next. The first type of stroke we will review is the ischemic stroke. There are two different types of ischemic strokes. And basically, an ischemic stroke is a deficiency of blood flow to the brain due to blockage of an artery. Ischemia is basically just a loss of oxygen to an area in the brain. And so we see that when we're talking about this kind of stroke. Most strokes, in fact, about 85% of strokes are ischemic strokes. So this is definitely the most common we'll see when we're working with an individual with aphasia. Two types of ischemic strokes. The first one is a thrombosis. And a thrombosis is when something builds up on the inside of an artery wall that eventually gets big enough to block the flow of blood past it. That's a thrombosis. A thrombotic stroke then is going to result in damage beyond that blockage in the artery. It can happen in any artery. Smaller arteries are obviously more prone to this. The other type of ischemic stroke is an embolus. An embolus is a blockage, and something's moving through the vascular system. It moves through until it gets to an artery that's too small for it to go through, and then it blocks the artery. I have on here that a clot forms and a plaque breaks off. Sometimes that happens. Sometimes it's other things that aren't necessarily previously attached to the wall. It could be an air bubble. It could be a number of things. But basically what happens is, it gets to an artery that's too small for it to move through, and it blocks blood flow beyond that. So an embolism is something that's moving through the vascular system. A thrombosis is built up on an artery wall, both with the same effect of blocking blood flow once they get large enough or get to where they occlude the artery. Now, I also have on this slide a transient ischemic attack, or TIA. One thing that we can see with ischemic strokes is that in some individuals we see a TIA ahead of time. They may have this disruption of the blood flow, so they have ischemia, but it resolves. The blockage moves through, it dissolves to an extent that the blood flow resumes, and the person goes back to prior functioning. The symptoms are the same as an ischemic stroke, but they resolve in about 24 hours or thereabouts. I have a link here that I encourage you to follow and watch this video explaining TIAs. But basically what we see is a mini stroke that resolves itself. Now, the second major type of stroke we can see in individuals is a hemorrhagic stroke. And a hemorrhagic stroke happens when we have blood on the brain tissue. It's not a blockage, it's an artery bursting open and then blood getting onto the brain tissue around it, also reducing blood flow beyond that area. So the two words I have here defined are hematoma, which is a pool of blood. We see that when your aneurysm, or when your blood vessel bursts, you see a pool of blood on brain tissue, and that's the hematoma. It can put pressure on adjacent brain tissue. So by putting pressure on the brain, it can cause damage to the cells in the brain cells themselves. It also blood-brain barrier. We have a blood-brain barrier that protects brain tissue from caustic or toxic substances, and blood is actually toxic to brain tissue, so it causes damage by direct contact with the brain. So a hematoma we see causing damage in a hemorrhagic stroke. The other term I have defined here is an aneurysm. Excuse me. And an aneurysm is a weak spot on a blood vessel, and what that does is then, as the blood moves through the blood vessel, over time, that weak spot will balloon up. It's just like you're blowing up a balloon with air. It will expand and expand and expand until it becomes so thin that it bursts with the pressure of the blood flowing through it. And that aneurysm bursting can cause a hematoma, which causes a hemorrhagic stroke. So these are terms that are really important for the other 15% of strokes that we see. What I have on this slide here is just a link to a video that will explain stroke in more depth than what I just did. They talk about signs and symptoms of the stroke and the treatment we can have for particularly ischemic strokes. So watch this video for a more in-depth explanation if you wish for more review. Here is just a real person story of a stroke, a young person who had a massive stroke, and it's the story from him and his family about the occurrence, the stroke itself, and recovery. So again, it's a video for you to watch to get a real example story of a stroke and recovery from that stroke. So we primarily focus on strokes when they happen in the left hemisphere of the brain because we understand that the language areas in the brain are primarily in the left hemisphere. However, we do have individuals who experience strokes in the right hemisphere of their brain, and they have characteristics that affect speech and language as well. So we will work with an individual with a right hemisphere CVA, and when we do work with somebody with that diagnosis, we'll see some different characteristics than we see for somebody with a left side CVA. Some of these symptoms we might see in that individual as a loss of movement on the left side of the body. Recall that the brain controls the contralateral side of the body, so when we see a right side CVA, it's the left side of the body that will be affected. We will see a lot of times quick and impulsive behavior in somebody with a right side CVA. The control we see from the right hemisphere of the brain impacts that sort of self-control for behavior. We see memory problems. The memory problems are going to occur anytime we have damage in the brain. Memory, different types of memory, different characteristics of memory are stored in different areas of the brain. So we frequently do see issues with this. This is prominent in a right hemisphere CVA. We see lack of attention to the left side of the body. That's different than lack of movement because the person may forget their left side of the body. They may just ignore it, even if they realize it's there. So they have a neglect of that side of the body. They can have trouble with swallowing. They have problems remembering how to do daily activities. Again, memory. So memory for daily activities, that procedural memory is affected in right hemisphere CVA. They can have difficulty speaking. It's going to be different than left hemisphere CVA, but they will have difficulty of speaking. A lot of the difficulties a person with a right hemisphere CVA will have are with discourse. They may have trouble maintaining a conversation, or their language may be off topic or tangential. So we'll see that with a lot of right hemisphere CVAs. Impaired expression of emotion. A lot of emotional recognition, perception, expression are controlled in the right hemisphere. So we'll see that with a right hemisphere CVA. They may have some impaired perceptual skills. The right hemisphere is much more relevant for overall perception. So we may see that in a right hemisphere CVA. And we frequently will see decreased insight into deficits. A person with a right hemisphere CVA may not realize they have anything wrong. They may not realize there's anything different. So that's another challenge we might deal with a person with a right hemisphere CVA. So you can see how while this does not affect primary language areas, it's going to be important for us, a lot of pragmatic skills and other aspects of language that we will care about. The left CVA, this is the side that we focus most on. And what we see with the left CVA is the loss of movement to the right side of the body. Again, contralateral control. One of the reasons why the right side control is important with left CVA, not just because of language, but because if we want someone to write or do something physical, they may have difficulty because since the majority of people are right-handed, they will have trouble with writing, even not related to language, just based on motor skills. A left CVA, a person will have problems talking and understanding, so we'll deal with aphasia in a lot of left CVAs. Problems with remembering how to do daily activities, problems swallowing, again, similar to the right CVA. These skills are controlled in both hemispheres, so we'll see this with someone with a left CVA. Also, lack of attention to the right side of the body. Again, the same thing as I talked about with the right hemisphere CVA. The neglect, the failure to attend, the forgetting that side of the body exists. We'll see that in a left CVA, contralateral control. So if we focus in on the aphasia, because after all, that's what we're dealing with mostly in this portion of the course, and also in our profession as a rule. Aphasia technically means without speech. So most of the time we're dealing with individuals who do have speech, but a disruption to it. So technically aphasia means without speech, but we don't use the word dysphagia, which would technically be more accurate, because that gets confusing with swallowing difficulties. So we use aphasia, and just traditionally we've used aphasia. But this is a disruption in using and understanding language following a neurological injury or disease. So the aphasia applies to language use no matter the cause. We don't typically use the term related to other causes like TBIs, right hemisphere damage, or dementia because of other components that go with those. And aphasia is strictly the language portion. So we might talk about people with TBIs or these other diagnoses as having aphasia-like symptoms, but because it's more complex and more skills involved with those, we generally preserve the term aphasia in connection with strokes or CVAs. So symptoms we see with aphasia can include comprehension problems. So if somebody has trouble with comprehension of language, this can occur in spoken language and in written language. So we don't know initially when we meet an individual if they're going to have trouble with reading and comprehension, but we will find out. Some will have it, some will not. So this can result from impairments to any of the linguistic processes related to comprehension. So any process we use in comprehending language can be affected. So we can be understanding the words coming in. It can be we understand the words, but we can't assign the meaning, and we can't connect the linguistic portions of the message. Any aspect of that can be impaired to impact our comprehension of language. So if there's a comprehension issue, it can be any step along that way. Speech fluency is the other side of the aspect of language use that we consider primarily. Speech fluency describes rate, rhythm, and ease of speech output. So anytime we're talking about fluency, we're talking about ease and pace or speed of speech production and the rhythm of it. So no matter how we use the word fluency, that's what we're referring to. And in this case with aphasia, it's going to be affected by that language ability, that difficulty finding words and applying words to the message we want to produce. With aphasia, it refers to the phrase length. Primarily, it's shorter phrases with aphasia. Those phrases may be telegraphic, not including functor words. It may just include the content words that we want to use, and it may not be all content words. Non-fluent aphasia, it produces short, effortful, halting speech. That's what I was just describing. The difficulty with producing speech, so it's non-fluent. Fluent aphasia can produce speech that sounds normal, but it contains grammatical and other errors. So we can have challenges with language in a fluent aphasia. So it's going to be fluent, but it won't have the content we need for language. and to be understood. So when we're talking about non-fluent aphasia, we talk about different kinds of naming disorders. So we have challenges with a person using these. Actually, I said non-fluent aphasia. Some of these apply with fluent aphasia as well. So it actually applies to naming can be difficult in all aphasia. Anomia is the first one I have here, and that's the difficulty with recalling the names of people, objects, locations, actions. So basically the inability to recall the word that you want to use to represent a concept that you want to convey. So when somebody has a naming disorder, they have anomia, they may have long pauses in their speech. So they may have a big pause where they're trying to think of the word. If they're self-conscious or otherwise don't want to have a pause, we might find circumlocutions. Circumlocutions is the tendency to talk around the word. Circum, around, locution, the word, speaking the word. So if they can't think of a specific word, they may describe it. So if I want to say, I need a pen, I may say something about, oh, you know, that thing you use to write with. I have paper, I need this thing to write with. Something along that line. They may talk around it. Paraphasias are also errors in naming. They have the word, but they don't quite get it right. We have two different types of paraphasias primarily, and that's semantic and phonetic. I'll talk about those on the next slide, but those are basically what kind of error I get in the name. Phonetic is I almost get the word, but I get a letter or two wrong. And semantic is I have the right idea, but I get the wrong word in a wrong related word. So I like to refer to these as near misses to the word. I almost have the word I want to say, but it's not quite right. It's either wrong semantically or phonetically. Neologisms are another error we can get with word finding, and those are just non-words. A neologism, technically that word means new word. So it's a non-word that you use in place of a word. So if I can't think of the word I want to say, I think I've got the word, but it's really not one. We might see this a lot in affluent aphasia as well. Jargon is sentences containing all or mostly non-words. So if I have a lot of neologisms or paraphasias strung together in a sentence, that's jargon. So jargon, again, is something you'll hear with affluent aphasia. It sounds smooth, it's a full-length utterance, but it doesn't make sense. A lot of that's going to be jargon with a lot of non-words in it. So here's some examples of speech productions we might see in aphasia. So the behavior on the left, the example on the right. So an anomic pause, you might say, can you hand me the remote? Trying to find the word, pausing. A semantic paraphasia, can you hand me the TV? The remote is related to the TV, I get the wrong word. A phonemic paraphasia, can you hand me the remote? Phonemic, phonetic, I use both terms pretty much interchangeably. Can you hand me the remote? Almost it, but not quite right. An anomic circumlocution. Can you hand me the clicker for the TV? Talked around it. Neologism, can you hand me the Jazzlepan? What the heck is a Jazzlepan? It doesn't mean anything. Jargon, grist me the Jazzlepan. Not only is it that one neologism, the rest of the utterance has been replaced. Well, one other part of the utterance has been replaced with a neologism. So it doesn't make any sense, even though it sounds like a sentence. Agrammatism, you remote, leave out all those extra words, get to the point. Only the telegraphic, it's speech. I just convey the word that I need to say. I can't get the rest, so it's not grammatically correct. Paragrammatism, empty speech, fast the jazzleman on the choose. Again, very similar to jargon. It doesn't mean anything, but they think they're saying something meaningful. So those are just some examples of the kinds of errors we see in aphasia. So when we're talking about written language, sometimes we'll have issues with written language, sometimes we won't. And they can, again, take different forms, just like comprehension and expression in spoken language. Alexia or acquired dyslexia, primarily we'll refer to as alexia, is a difficulty in comprehending written language. So that's the difficulty with reading. after a stroke. A person who may be totally literate before suddenly can't read as a result of damage to the language areas. Agraphia is impaired written expression, so maybe they can read but they can't write. So we can have either or both of those. What I have here is an old video, but it's a nice illustration of Alexia without agraphia. So the person in the video can't read the words presented to her, but she can write words when she's asked to. So I encourage you to watch this video as well as a nice example of how you can have the ability to write without having the ability to read. So it's an interesting characteristic that is nice to be able to observe. So let's go back to a bit of neuroanatomy for when we're talking about aphasia in language. So we've got we see the left hemisphere of the brain here, and we can look at what lesions will, result, what kind of issues will result from lesions in the two different language areas. Broca's area, we'll see lesions that involve spoken language. In Wernicke's area, we'll see lesions that are relate to comprehension. So Broca's area, non-fluent aphasia, spoken language difficulties. Wernicke's area, we see fluent aphasia with comprehension difficulties, but expression is smooth and fluent. Now, I can't say it's good, but it's smooth and fluent. So what we see then with these is the non-fluent aphasia in Broca's area, effortful, short utterances, pretty good comprehension generally. Wernicke's area, we see fluent aphasia that's grammatically structured speech. We have errors in naming, and we have most important. A big part of this is impaired comprehension. So it's fluent, but the errors are related to the impaired comprehension. So we see these kinds of issues with these lesions. So I'm sure you've seen this before. If you've been in one of my other classes, you definitely have seen this or a similar structure before. And this is how we're going to differentially diagnose aphasia. So we start out with somebody with aphasia, and we want to identify what kind of disorder they actually have. First thing we look at, are they fluent? If they're not fluent, we'll go down the left side of this diagram. If they are fluent, we'll go down the right side of this diagram. After we determine fluency, then we have to determine what's their comprehension like. So we determine yes or no, can they comprehend language? Once we determine their comprehension status, then we want to see, can they repeat what's said to them? So then we can diagnose very specifically the type of aphasia based on whether they can then repeat once we know comprehension and fluency. And what this diagram shows us is the different types of aphasia that the person could have based on their responses to tests related to these skills. I apologize for the part of the diagram being obstructed, but it's part of the video. So first of all, as I said, we want to look at, are they fluent or are they non-fluent? This is going to give us a lot of information about receptive versus expressive aphasia. Generally, if we're talking about fluent aphasias with poor comprehension, it's a receptive aphasia. Non-fluent aphasias with good comprehension, it's an expressive aphasia. So we have different types. We most often focus on Broca's and Wernicke's as the examples. Excuse me. The two primary examinations we use to diagnose different types of aphasia are the Boston Diagnostic Aphasia Examination and the Western Aphasia Battery. There are others, but these are the most commonly used batteries to assess types of aphasia. These examinations measure all aspects that could be affected with aphasia. Naming, comprehension, repetition, reading, writing, math skills can be affected. So these measure all of those at varying levels, from single words, single syllables, to full utterances and paragraphs. So these are comprehensive tests that gives us information about the aphasia. So again, with this, going back to the idea of Broca's and Wernicke's being our most commonly diagnosed aphasias, in Broca's aphasia, we see this when we have damage to Broca's area in the brain. I've already indicated this in the diagram of the left hemisphere. And lesions are in that left frontal lobe area, around that area, affecting Broca's, the expressive language. We generally see impact comprehension, probably a little mild difficulty with comprehension, but it's generally intact. The biggest impairment is in naming. We have a lot of anomia, a lot of those kinds of errors with naming. And then when we're looking at repetition on the examination, it's going to be similar to spontaneous speech. Repetition itself will not be impaired except where it's impacted by the ability to produce the word. So it's going to be similar to the spontaneous speech on the testing. In Wernicke's aphasia, they're going to be fluent. The damage is to Wernicke's area, the lesions in that upper left temporal lobe area, the upper posterior area of the temporal lobe. We'll see damage in that area. So when any kind of any testing is done, medical vision, testing to envision it, MRIs, CAT scans, etc., we'll see it in that left temporal lobe. In Wernicke's, generally it's moderately to severely impaired comprehension. So it's going to be more severe than Broca's, certainly. That's going to be one of our primary focuses, is on that comprehension. Impaired naming, because they won't be able to, if they're not comprehending, they may not comprehend the words they're saying even, and the words may come out unclear because of that comprehension. Repetition, again, is similar to spontaneous speech. It may be fluent, but they may have words that are not particularly sensible. They may be non-words when they're trying to repeat. Again, it's related to that comprehension. Finally, I have 3 more videos for you to watch for more information related to the types of aphasia. I have an example of Wernicke's aphasia, an example of Broca's aphasia, and an example of, actually she has non-fluent Broca's aphasia, but she's another young person, and this is a few years post-stroke, so she talks about her recovery and her current status with her stroke. So watch these videos for some good examples of these before watching the Master Clinician videos, so you can have an idea what you're going to see and what are some examples of different individuals with aphasia. So these are just some more to give you some exposure to examples of aphasia. Now, lastly, I want to make sure I give you some information to keep in mind when you're watching the videos on the Master Clinician Network. When you're watching these therapy sessions, I want you to try to identify what type of aphasia the client is exhibiting. Are they fluent or are they non-fluent? Kind of get an idea of what you're watching in these videos. What strategies do you observe the clinician utilizing to facilitate communication? So what do you see the clinician doing to try to make that language better for the client, make them more fluent, or help them to get more meaning in their words, help them improve comprehension? Pay attention to what the clinician is doing to help. What aspects of language are most impacted? Is the person's language most affected in terms of form, or syntax, the grammatical structures? Is it more impacted on content, their semantics, their word finding? Is that most affected? Or use? Is it more of a pragmatic issue you're seeing in that client? So keep these things in mind when you're watching the video. Then as you answer the questions after the video, having observed these things should make it easier for you to answer those questions. So keep those things in mind. So I hope this is helpful in getting you prepared and ready to watch those videos on adult language. And then as you can enjoy watching them, see what you observe in the clinician, see what you observe in the client, and kind of get an idea of what goes into that therapy session. And enjoy it, and I will be back to talk with you more about child language once you finish your adult language videos. Have a good time, and I'll be back.